Thank you. Thank you, Dr. House and Dr. Fisher. Distinguished members and guests, thank you for allowing me the opportunity to present our findings. IPMNs, intraductal papillary mucinous neoplasms, are mucinous lesions of the pancreatic duct with varying degrees of malignant potential. The oncological risk is assessed based upon patient symptoms, radiographic findings, and cytopathology, but can only be definitively determined based upon the pathology of the surgical specimen. The indications for surgical resection include persistent symptoms, commonly recurrent pancreatitis, or any time the risk of malignancy outweighs the risk of surgery. This can be a difficult decision due to the fact that many of these patients are elderly with multiple comorbidities. Further complicating this decision is the fact that IPMN are commonly multifocal. Current practice for the surgical treatment of multifocal IPMN is a selective resection of the most clinically significant lesion, be that the one most likely causing symptoms or the one with the highest risk of progression to malignancy. This process of selective resection, however, may leave patients with residual disease within their remnant pancreas, be that positive radiographic evidence of disease or positive margins. The risk of progression to invasive disease in patients with residual IPMN is unclear, and whether the natural history for patients with positive residual disease is different than those without residual disease is also unclear. Further, when to perform a re-resection in this patient population is unknown. The aim of this study is to determine if in patients with known residual IPMN within their pancreatic remnant, if they have an increased risk of progression to invasive cancer or decreased survival. Our hypothesis being that the risk of progression to invasive cancer in these patients with known residual disease will be increased, and that this will hold true of both groups, those with positive radiographic evidence and those with positive margins. To address this hypothesis, we employed the following methodology. All patients presenting to Indiana University Hospital between the years 1991 to 2010 for segmental pancreatectomy for non-invasive IPMN were included. Patients were excluded if they were found to have invasive disease on initial pathology, if they were treated with a total pancreatectomy, or if they had follow-up less than 3 months. Data regarding their demographics, pathological findings, operative reports, and clinical factors were compiled. These patients were analyzed in 2 groups. The first group, those with known residual disease, positive radiographic findings, and positive margins, and the second group with complete surgical clearance, those with no known residual disease. These data were exposed to the appropriate statistical tests, and the results are as shown. During our study, 271 patients underwent resection for IPMN. Of these, 28 were excluded due to the fact that they were treated with total pancreatectomies, leaving 243 patients undergoing segmental pancreatectomy. Of these, 52 were excluded due to invasive disease on primary section, which left our study with 191 patients undergoing segmental pancreatectomy for non-invasive IPMN. Of these, 38 patients had positive residual disease, one of which went on to develop invasive cancer for a risk of just over 2%. Of the 153 patients who had no residual disease, 3 went on to develop invasive cancer for a risk of just under 2%. Comparing the 2 groups, those with residual disease and those without, their clinical and pathological features are shown. There were no differences with the exception of mean follow-up, which was 73 compared to 41 in the group with positive residual disease. The age, gender, comorbidities, type of operation performed, pathology at initial resection, and size were similar in both groups. When looking specifically at the 38 patients with IPMN within their pancreatic remnant following initial resection, 8 had positive margins only, 23 had positive radiographic findings only, and 7 had both positive margins and positive radiographic findings. All of the positive margins in this study were low grade, and of the 15, 6 were within the main duct, with the other 9 in the branch duct. The only patient to develop invasive cancer in this group was a patient with low-grade positive margins within the main pancreatic duct. We found no difference in progression-free survival when comparing all patients with residual disease following initial resection and those without. Additionally, when looking only at patients with positive radiographic findings only compared to patients without residual disease, we found no difference. Of the 153 patients without remnant disease following segmental resection, 31 developed new lesions during follow-up. Of these, 3, or about 10%, had invasive cancer. The interval to development of invasive IPMN was 60 months with a range of 20 to 99 months in this population. Cytopathology was able to diagnose 1 with malignancy, but was not a reliable predictor of malignant IPMN in these patients. Of these 3 patients, 1 was successfully re-resected. No survival differences noted in the 31 patients developing new lesions versus those without when taken from the time of initial resection. In total, of the 191 patients included in our study, 4 went on to develop invasive cancer following segmental pancreatectomy for non-invasive IPMN, and they are shown here. 3 of these patients had high-grade IPMN on initial resection. 3 had no residual IPMN within their pancreatic remnant following their initial resection. Cytopathology was able to diagnose 1 of these patients with malignancy. Their progression-free interval for these 4 patients was 54 months with a range of 20 to 99 months. 3 of the 4 of these patients had significant symptoms at the time of their diagnosis of invasive IPMN. And of these 4 patients, 2 underwent re-resection, 1 curative R0, 1 with an R1 resection due to vascular invasion, both of which are alive. 2 patients were inoperable, 1 of which due to distant metastases and 1 due to local invasion. Both of these patients were not followed closely following their initial resection. 13 re-resections were performed in our study. Of these, 4 were found to have no IPMN present, 5 were found to have low grade, 2 with high grade, and 2 with invasive. The indications for surgery are also listed. To summarize our findings, the risk of invasive cancer in patients who underwent segmental pancreatectomy for non-invasive IPMN was about 2%. When including high-grade lesions, the risk of malignancy was closer to 3%. There was no increase in risk of patients, in risk for invasive cancer or decreased survival in patients with residual disease, be that positive radiographic signs or positive margins. Patients with a positive margin within their main pancreatic duct may represent a high-risk group, with 1 out of 6 of the patients in our study going on to develop invasive disease. High-grade dysplastic IPMN at initial segmental resection can also confer increased risk, with 3 out of the 29 patients in our study going on to develop invasive cancer for a risk of about 10% as well. Patients who develop new IPMN following segmental pancreatectomy in a previously negative remnant may represent a 3rd high-risk group, with 3 out of the 31 patients in our study progressing to invasive cancer. These findings must be interpreted while keeping in mind the following limitations. This study was a retrospective analysis over a significant time period, nearly 20 years. There have been significant changes in operative strategies such that it is now more acceptable to allow for low-grade margin-positive residual disease, which results in a shorter follow-up in our patient study with positive residual disease. There have been significant changes in surveillance strategy and significant advances in cross-sectional imaging, such that many of the new lesions that we're actually describing could potentially be only newly discovered lesions and not new lesions at all. In addition, with improved imaging, there would be more patients with positive radiographic evidence of disease later in our study. Given these limitations and the data presented, we feel they support the following conclusions. The current practice of selective resection of the most clinically significant lesion in patients with multifocal IPMN is safe. Reasonable attempts should be made to clear all IPMN from the main duct, but it may not be necessary if it would impose significant morbidity. Patients with high-grade dysplasia or main duct margin positivity at initial resection, or patients with new IPMN developing within a previously negative pancreatic remnant, may represent high-risk group and should undergo more intensive surveillance. Thank you.